Thank you, Jordan, and thanks for the pressure. Again, I'd like to thank the organizers for bringing back to this outstanding meeting of GI oncology. And my talk is meant to be positive in terms of what the future will hold, and it's also addressed to many of the young investigators and doctors who are in this audience. So again, thank you for having me here. Now, these are my disclosures. A quick mention of some of the things we know about. These are 4 studies that really established frontline therapy, and you can see that I agree with the previous speakers that the benefit so far has been very modest. And then we moved into targeting signaling pathways, and I was involved in several of trials you can see here where we tried to target EGFR, combine it with IGF-1R, and there are even studies gone into the angiogenesis pathways, and all these studies failed. And then we learned early on that trying to target one gene product or one pathway in this disease, which doesn't have a driver mutation so far, is really not going to be beneficial. And to prove that, I just looked at some of the studies, or in fact, this is as many as I could find between December of 2015 and June of 2017 today. And you can see that different drugs in different classes of agents really failed. These include drugs that targeted the stem cells. We thought that would be great, like the Notch2/3 inhibitor. Vaccines failed, and a number of other tyrosine kinase inhibitors, and even JAK1 STAT pathway, which we thought was great, failed. So really we have something which is important in this disease, and we have learned a lot in the sense that we should be more innovative and think better in terms of finding the pathways we want to attack, but also how to do clinical trials. Now, some people may simplify it and say, let's match the tumor to the treatment. Well, you can do that, but this is the genetic profile of this disease. Most of the patients have KRAS mutations. In fact, if you do some of the newer NGS studies, you will see 100%. And if you want to look for a driver mutation or something which you can target like HER2/neu, it's really less than 2%. Many patients have tumor suppressor gene mutations, which, as you know, is not that easy to target. And DNA repair is becoming important, but again, in a small proportion of the patients, and you heard about MSI high. And therefore, we really have to think differently about how we categorize our patients and how we design our treatments. Now, when I go back and look at the studies that are being done in investigations, it's hard to say, how can I really describe such a topic without making some sort of a categorization? And the best one I could come up with, and maybe you can help me with a better one, is targets that really look like more linked to the disease as we know it in terms of biology, targets that are more like generic across cancers, and then, of course, we may never have to forget the immunotherapy. So the microenvironment in this disease is very unique. And it doesn't really need a pathologist to tell you that there's a lot of fibrosis, stroma here, and this is really biologically active. It's not really there like a scar tissue after an operation. It's very desmoplastic. We heard about that. It limits drug access, and it's also described as an immune desert. So there are a number of things we can do for the microenvironment, but you really have to look at the picture on the right, and you can see that this is a very dense neighborhood, and also it's a very diverse one. It has a lot of players there, from macrophages, blood vessels, some T lymphocytes, Tregs, plenty of them. And there are a number of things that we can do to the microenvironment. Hedgehog inhibitors, I'll come back to that. Recombinant human PEG-PH20, we talked about that. I don't want to spend any time on it, only one slide. CD4 agonists, vitamin D analogs, FAC inhibitors, all these are examples of what is currently being done. But let me just make one point. The hedgehog inhibitors were based on very robust preclinical work. When it went to the clinic, in fact, it showed the opposite, patient did worse. So one thing which we have to keep in mind is that when we target the microenvironment, we also have to understand that, or believe that the microenvironment has its benefits and harms. And sometimes when we target it, we may create harm. That's something we have to keep in mind. Now, the pegylated PEG-20, you heard a lot about it today, and I have to tell you that the drug has also been combined with FOLFIRINOX. That trial had to be stopped because we did not think that going further is necessary in that study. We would not see benefits. So that's something which we observed, but that was a different trial in a sense, combined with FOLFIRINOX, different drugs, and also not preclinically validated in terms of a combination, and also it was a study in all comers. But we're supporting the phase 3 trial, which we think is going to be very exciting. Now, moving on in the neighborhood of the microenvironment, the tumor activate macrophages and also the myeloid-derived suppressor cells. These are also very important, we think, based on what we know about the biology of cancers, including pancreatic cancer, that they cause many of the bad things we see, drug resistance, immune suppression. And there's also evidence that if you target these cells, they may be able to reverse some of these effects. Now, this is a very interesting trial, which is a pilot trial published last year, and it was a combination of an anti-CCR2 agent, which is from Pfizer, in borderline resected locally advanced disease, and there was significant activity with it. And this trial was done in such a way that they also loaded a lot of cognitive science, and in fact, they managed to come up with some interesting findings. So ourselves and others were interested in taking it further. Now, a randomized phase 2 trial was initiated, and then it was terminated early using the same compound, but there are other studies that are currently ongoing. One study completed using CCX872, but there are other trials looking at other molecules also, which is worth investigating. And in fact, ourselves were looking into a study to combine with FOLFIRINOX using the CCX8 compound. So this is an area which is really going forward. Now, I just want to take a second here, a pause, and say what I'm describing and what you heard today means one thing, and that is try to think of these things, how you're going to put them together, because that's the theme of my talk. None of these drugs by themselves are going to create a major benefit. We know that. But at the same time, combinations might be very synergistic. Now, DNA repair has been shown from the genomic and transcriptomic analysis to be a subset of patients who really can benefit from some special treatments. The challenge here is that we always think of BRCA1, 2, PARP-B, but DNA repair defects really extend beyond that. And what is currently being done in terms of research is trying to figure out how to extend that group of patients so we capture as many patients who have DNA repair defects. And there are a number of attempts to do that. It's not easy, but it's something I think which is going to be solved. Now, if we stick to the DNA repair defects, BRCA mutations, there is certainly benefit, as Dr. Tempera showed you, from the use of platinum compounds. The first time we ever used 20 years ago gemcitabine cisplatin, it was in a 35-year-old lady who had an almost complete response to the point that we took her to liver resection. She probably had a BRCA2 mutation that we didn't know of. PARP inhibitor single agent also have activity, but again, you have to be also thinking of these drugs by themselves may not be the end of it, because still, if you look at the PARP pathway, DNA repair, it's still very complicated. Currently, there are a number of clinical trials looking at PARP inhibitors, and in fact, this is an area which is actively investigated. However, you need trials that go across institutions and countries and continents to be able to do that. One of the promising new drugs or strategies is to try to target an enzyme called NQO1. This is an enzyme which is overexpressed in pancreatic cancers and some other cancers. Its expression is high relative to normal tissue, but also in pancreatic cancer there is a low expression of catalase, which is the reverse enzyme which you need to go down. Again, for the sake of time, I'm not going to spend much time on it. And this enzyme, targeting it with a drug, also gives you the opportunity of using a PARP inhibitor with it. And this is work being done for a while now. And NQO1 can activate a drug, which is ARQ761. And when the drug is activated, there's a lot of ROS released and hydrogen peroxide, which leads to DNA damage and also cell death, but also overwhelms the PARP pathway, and therefore you can go in with a PARP inhibitor. And again, if you look at the preclinical work, it's very impressive. And this has led to a clinical trial that is currently started, which is a multi-institutional trial. And this is work being done by Dr. Begg and Dr. Boothman. So this is an area which is really interesting. Somewhere close to it is targeting metabolism. We have always been engaged with targeting signaling pathways, stem cells, etc., but there are areas which may be very important. Now, the previous example I showed you doesn't require the cell to have a specific gene mutation, or at least that's what it shows at this time. These are drugs that we may be able to use them more liberally, not being so much limited by what the profile is in the tumor. Now, with the metabolism, we heard about the Warburg effect, which is the way the cancer cells metabolize glucose as opposed to normal cells. The metabolism pathways also are linked to other genomic changes in the tumor, mutations which can also regulate them. So this is one way of trying to move into combinations where you have a drug that targets metabolism to do that. One drug, which is called CPI-613, this selectively blocks two tricarboxylic TCA cycle enzymes, the pyruvate dehydrogenase and also the alpha-ketoglutarate dehydrogenase. And by targeting those enzymes, it increases the amount of the cell damage. And this drug, which is also going into phase 3 now, has had a phase 1b study, which was published recently, or is going to be published by Angela Allister, who's now in New Jersey. And in this trial, they combined with FOLFIRINOX using lower doses of FOLFIRINOX. And they show some interesting benefit from the combination. This is preliminary of phase 1. The interesting thing about this is not only the combination appears to be more effective, but also the fact that you're allowed now to use a lower dose of the combination with the drug. And this is leading into a phase 3 trial, which is using the combination, again, lower dose of the FOLFIRINOX versus full dose FOLFIRINOX, including the bolus FAB-FU. And this trial hopefully will start by the end of the year, or more realistically, early next year. And it's sponsored by the company Raphael, which is previously called Cornerstone. Now, what about another more pancreas-specific type of approach? Mesothelin is not only expressed in pancreatic cancer, but pancreatic cancer is one of the tumors that really express a lot of this protein, and mesothelioma obviously will be the other one. And in this context, there are multiple ways where you can utilize the mesothelin expression in the pancreatic tumors to try to attack the pancreatic cells. And you can see here that you can attach an immunotoxin, or you can do CAR T-cell type of strategy. And in fact, this is an area which is becoming very busy. There are a number of studies, a number of approaches that is really trying to capitalize on the expression of the mesothelin on the surface of the tumor cells. And this will be interesting in a sense because this is one approach that we haven't been successful using other antigens. Now, what about others? Well, an old friend, KRAS. KRAS is 85%, 90%, 100% of the patients, and it appears to be a target that we would like to go after. However, KRAS has been very difficult to try to drug it directly. And one of the reasons for that is that it's a type of the molecule. It has very shallow grooves, like a golf ball. It's difficult to get a drug to sit there and try to inhibit it and stay there for a long time. So basically, KRAS has become a difficult target, although we still believe that if you hit KRAS, it might do benefit. And the KRAS is not only in pancreatic cancer, so it's a strategy worthwhile developing. At this point in time, a lot of studies have been doing blocking downstream of signaling of KRAS. However, MEK or AKT, these as single agents failed. Some in phase 3 trials, the MEK pathway. We also tried a study where we combined AKT and MEK together, and in fact, the control arm did better than the experimental arm. So at this point in time, we don't know what would be the best way to block the downstream pathway, although we continue to do that. One way, which is new, to try to directly go after KRAS is using engineered exosomes. This is a delivery where you can put the siRNA into the system intravenously and home on the tumor cells to try to, and this was a recent publication by the MD Anderson group in Nature. There's also a T-cell transfer technology that has had an article in New England Journal of Medicine. So these are things which we might be able to help us in the future, but certainly this is an area which also made the NCI create a consortium of investigators to try to find an answer to RAS mutations. Now, keeping in mind that this is a disease that has a lot of RAS mutations, and keeping in mind that this is a disease that had a lot of P16 mutations, but going back to the cyclin D1 and the CDK4/6, you know that it's important. This complex regulates the cell cycle transition from G1 to S through its work on the dissociation from the E2F from the RB, which is a tumor suppressor gene. And as you know, since the tumor suppressor gene is removed at P16 a fair proportion of patients, and also with the RAS being on top of it, and the cyclin D1 also gets signals not only from MEK and AKT, but I put them here, but there's a number of others. So one thing which may make sense is, in the absence of P16, is to try to block the CDK4/6 MEK or CDK4/6 AKT. So this is an example of combinations, and you can call them downstream combination of KRAS, but at the same time taking into account the fact that P16 does not exist. And there are a couple of clinical trials that are very interesting. One of them is ribociclib with the trametinib, and another one which is abemaciclib plus another target agent, which is, and there's one combining it with a AKT inhibitor. So these trials will be very interesting to see in a disease which biologically makes sense to have such an approach of therapy. Now, cancer stem cells, we talk about them all the time, and we tried to hit them with the Notch inhibitors. We couldn't. The question is there any other way? And STAT came up. Someone brought up STAT, which is not a good player. And this drug, which is Nab-paclitaxel, in fact, it's an oral agent which targets STAT3. And by doing that, it inhibits the proliferation of the cancer stem cells. And this drug has now gone into the clinic. And just to give you an idea of what it does, this is a study that was presented by Dr. Tony Saba, our colleague, phase 1b/2 study in 66 patients, combining it with Nab-paclitaxel gemcitabine, and there was some interesting activity. Interesting in a sense, PFS is a bit more than what we expect, 7.1, and the median survival 10.7 months. By looking at the waterfall plot, there was a lot of activity in terms of tumor shrinkage. The main side effect which adds to the Nab-paclitaxel is GI toxicity. Now, this has gone into a phase 3 trial, and to my best knowledge, this is the largest phase 3 trial I can see, 1,132 patients. And this will be plus minus the Nab-paclitaxel using Nab-paclitaxel as the platform. But they will have a futility analysis after 1,200 events. So this will be a very interesting trial to watch for, especially with this number of patients going on it. Now, what about immunotherapy? Let's switch gears. So you heard everything you need to know. It's non-immunogenic, it's a desert, there aren't that many cells in it. And the most important thing is that attempts so far of trying to use one modality, whether it's a vaccine or a PD-1 inhibitor, has not really worked in this disease. So what do? We put combinations, and you can have lots of combinations. So these are the combinations. There's a select number of drugs that are being combined together with PD-1 inhibitors. And also put one here, which is SBRT. Now, radiotherapy is also thought to be a good sort of treatment to add to a PD-1 inhibitor, because radiotherapy can kill cells, release neoantigens, abscopal effect we call it. So that's also part of these mixes that we're using, keeping in mind we're also doing CTLA-4 combinations, etc. The reality is that if you're sitting there saying which study I want to do, you can do any study you want with the combinations, because you'll find a good rationale for any of these. But the question is, how do we really go for the right combination, keeping in mind preclinical work is difficult in this area of research. So there are a lot of studies you will see. So my final slide before I go to conclusions is that the way I see the future is that we're doing the clinical trials. Now we're doing the right clinical trials that link to biology, which is on my right. up there. So we're doing the right clinical trials, stem cells, metabolism, stroma. So we're doing the right trials to get the right tools. But also at the same time, we have to really study the profiling of and I call it profiling, not genomic, because it has to be comprehensive profiling, including the host itself, the patient. And then what we end up with, a lot of clinical data, a lot of basic data, if you call it, put them together, that's big data. And then these are where the action will be, trying to work on consensus molecular and metabolic classifiers. Now, when I say working on consensus molecular, I don't mean just dry consensus subgroupings that doesn't help you as clinicians or researchers what to do with it. We have to find a better way of trying to do that. And once we've done that, the future is in combinations, and the future is in personalized combinations. But this is the process that I firmly believe is going to be happening and should happen. Unfortunately, we're still at the beginning of it, if you look at what you heard today and what I'm telling you. But I think just looking around of what people are investing in, I think this area is going to be moving, hopefully, in the way we'd like it to move to get answers quicker, but also I believe that this is probably the best way, and still the natural way. This is no-brainer. So to conclude, there are several areas of interest and promise: DNA repair, HA, mesothelin, etc. It's too early for immunotherapy. It's going to be a combination, but God knows which combination will be the best. There are a lot of combinations being tested. And once we start to get the promising agents going through the phase 2 and close to phase 3, I think we have to sit together and bring those two, really put them together, because one of them is not going to do it. You have to go into the combinations, but they have to be rational combinations, and they have to be not the way we've done it in the past, empiricism, which is easy for us to do. And the other thing which we really are very weak on, and I think that will take another 2 hours of talking, is how do we do clinical trials that has to be smart and also very cost-effective. And with that, I hope I gave you an idea of what I think of where the future is going, what we have now, which is interesting. And with that, again, I'd like to thank you all very much.